Bismillahirrahmanirrahim. Assalamu alaikum. Friends, welcome to the channel. Today I will be talking to you how to approach a case of jaundice. You know it very well if you talk about what is the definition of jaundice. It is the yellowish discoloration of sclera, skin or mucous membrane due to increased bilirubin level in the blood. Manifestation of jaundice occur when bilirubin level is more than 2.5 to 3 mg per dl. Point to be noted. Just to inform you that normal serum total bilirubin level is 1.2 mg per deciliter. Jaundice is actually a symptom and not a disease. Usually, it is first noticed in the sclera of eyes. So, when the patient of jaundice come to us, how to approach? For that, we got to learn some basic concepts about jaundice. So, you know it very well that unconjugated bilirubin is made from the breakdown of hemoglobin. It is the heme part of hemoglobin which break down into iron and unconjugated bilirubin. Unconjugated bilirubin is water insoluble. This unconjugated bilirubin come to the blood and get attached to albumin. So, obviously, any condition which lead to huge hemolysis or mesiohemolytic anemia will produce large amount of unconjugated bilirubin. So, if excess hemolysis occur, it will increase unconjugated bilirubin, and we call this as pre-hepatic cause of jaundice. So, obviously, when this patient come to us where we are suspecting pre-hepatic jaundice, what we will find? There will be pallor because of anemia, and there will be a definite history or a clinical condition suggesting of mesiohemolysis. Now, if we have to advise one single test to confirm hemolytic anemia as a cause of jaundice, what test we advise? So, best initial test will be reticulocyte count. It will be increase in hemolytic anemia. This is the test which really confirm that there is hemolysis. Normal retic count is 0.5 to 2%, but in mesiohemolysis, the count may be as high as 5 to 10%. Multiple choice question. Since liver is not involved in these patients, so liver enzymes will be normal. And there will be increased unconjugated bilirubin in serum, which is called unconjugated hyperbilirubinemia. What is the definition? When conjugated bilirubin is less than 20% of total, or we can say when unconjugated bilirubin is more than 80% of total bilirubin, that means unconjugated hyperbilirubinemia. Point to be noted. Okay. Now we come to the pathway followed by unconjugated bilirubin normally. The unconjugated bilirubin then come to the liver where its conjugation occur and conjugated bilirubin is formed. So, if any disease of liver occur like viral hepatitis, then we label as hepatic cause of jaundice. Suppose there is no problem in liver is normal and problem lies somewhere outside the liver, somewhere in the biliary tree, and this is specially seen in common bile duct stone or gallbladder stone or maybe carcinoma head of pancreas. They lead to obstruction to the normal flow of bile and consequently lead to increase in conjugated bilirubin. Now, what is the definition of increased conjugated bilirubin or conjugated hyperbilirubinemia? When conjugated bilirubin is more than 50% of total bilirubin, we call as conjugated hyperbilirubinemia. Multiple choice question. Below 20% is prehepatic, and when it is between 20 to 50%, we call as mixed, which is clinically seen in hepatic jaundice. Now, in patients where we have conjugated hyperbilirubinemia, what are the special things which we see? Of course, jaundice will be seen in all the three varieties, but what features will really indicate on clinical examination or history that it could be a case of post-hepatic jaundice, also known as obstructive jaundice or surgical jaundice. Why we call it surgical jaundice? Because these conditions are usually managed by surgeons. So, points which are in favor of obstructive jaundice include fever, itching, and abdominal pain. These are the classical features that we see in obstructive jaundice. And remember, if you are suspecting a case of surgical jaundice, the initial investigation should always include ultrasound abdomen. It is the best initial investigation to look for this. Okay. So now you are clear about the prehepatic, hepatic, and post-hepatic causes of jaundice. Having learned the basic concepts, now let's come to how to differentiate I will discuss it in table form by which you can differentiate. So, in prehepatic jaundice, unconjugated bilirubin will be more than 80% or we can say conjugated bilirubin will be less than 20%. Liver enzymes like SGOT, also known as AST, and SGPT, also known as ALT, it is normal because liver as such is not involved in the disease. Now, what happened to alkaline phosphatase? Alkaline phosphatase is normal in pre-hepatic jaundice. Okay. What about bilirubinuria? Means bilirubin will be there in urine or not. Unconjugated bilirubin is attached to albumin, which is a big molecule, and not filtered in urine. That's why in case of prehepatic jaundice, there will be no bilirubin in urine. Now come to hepatic jaundice. In hepatic variety, conjugated bilirubin will be 20 to 50%. AST and ALT level will be highly increased in hepatic jaundice. Alkaline phosphatase is increased in hepatic jaundice. Conjugated bilirubin is not attached to albumin and it is also water soluble. So, you will get it in the urine. Now, move on to post-hepatic jaundice. I told you in conjugated hyperbilirubinemia, conjugated bilirubin will be more than 50% of total bilirubin, which is a feature of obstructive jaundice. Alkaline phosphatase is highly increased in post-hepatic jaundice. Because alkaline phosphatase is usually secreted by bile duct canaliculi, that's why in obstructive jaundice, alkaline phosphatase level is very high. And of course, you get very dark color of urine in obstructive jaundice because the conjugated bilirubin is very high in urine. These are the points what you got to remember. Thank you very much.